Welcome back to the deep dive. Today, we are tackling a big one, a really big one.
It's kind of the final destination, isn't it?
It really is. It feels like so many other roads in cardiovascular medicine, they all sort of lead here.
That's no exaggeration. I mean, think about it. You survive a huge heart attack, you could end up here.
Right.
You've had untreated high blood pressure for, say, 20 years.
You end up here.
You've got a valve problem that goes unfixed. You end up here. It's the final common pathway.
We are talking about heart failure. And I have to say, just the name itself, heart failure, it's just terrifying.
It really is.
It sounds so final, like a switch has been flipped to off,
Yeah.
you know. The screen just goes black.
It's a branding problem, honestly. People hear failure and they think the heart has just stopped beating. They're picturing a flat line on a monitor.
Yeah.
But based on the source material we're looking at today, which is, I mean, it's a really comprehensive deep dive from a major medical text, it's not a moment. It's not a static event at all.
It's a process.
It's a progressive clinical syndrome. That's the key phrase we need to start with. It's really the story of the heart trying and then failing to meet the body's metabolic needs.
So it's still pumping.
Oh yeah, it's pumping. It's just not pumping enough blood to keep up with what the organs actually need.
Or, and this is a really interesting point the text made, it can only do the job by working at these insanely high pressures.
Precisely. The tank isn't necessarily empty, but the pump is working so hard against all this resistance that the pipes are about to burst.
Wow.
And our mission today is really to decode that. We're not just going to list off a bunch of drugs. We want to understand the why.
The feedback loops.
The complex feedback loops. Because the most fascinating thing about heart failure, and really the thing that keeps doctors up at night, is that the very things the body does to try and save you
are the things that end up killing you.
Exactly.
That's the neurohormonal model, right?
Yeah.
The body basically sabotaging itself.
That is the absolute core of it. It's a tragedy of physiology. But before we get into the weeds on that tragedy, we have to define the beast. What does the text say heart failure is structurally? Because it's not just one thing.
Right. The source divides it into two main buckets. It's based on what's actually going wrong with the muscle mechanics. You've got systolic dysfunction and diastolic dysfunction.
Mm-hmm.
And reading this, it seems like understanding that distinction just changes everything.
Oh, it changes diagnosis, treatment, prognosis, everything. So let's take bucket one, systolic dysfunction.
Okay, this is the pumping problem.
Yep. This is what most people think of when they picture a weak heart. The heart muscle has lost its contractility. It just can't squeeze hard enough.
And this is often after a heart attack.
That's a classic cause, yeah. A myocardial infarction. Because part of the muscle has literally died and it's turned into scar tissue.
And scar tissue doesn't pump.
It's dead weight. It doesn't squeeze. So the rest of the muscle is trying to do all the work, but it's just overwhelmed. The heart becomes this boggy, dilated, flabby sac. It fills up with blood, sure, but it can't push it out effectively.
And this is where that famous number comes in, right? The LVEF.
Yeah.
The left ventricular ejection fraction.
The LVEF is the scoreboard. That's how we keep track. In a healthy heart, every time the left ventricle squeezes, it pushes out, say, 55 to 70% of the blood that's in there.
That's a normal ejection fraction.
That's normal. In systolic heart failure, that number just drops. It goes to 40%, 30%. I mean, I've seen patients walking around with an ejection fraction of 10%.
10%, that is wildly inefficient. It's like a car engine that only uses a tenth of the gas you put in it.
And it leaves the rest just sitting in the tank, bogging it down. So that's systolic. But then you have bucket two, diastolic dysfunction.
The filling problem.
The filling problem. And this one's a bit more counterintuitive because, like you said, it's not about the pump strength.
Yeah, explain that. Because in this case, the squeeze is actually fine.
The squeeze is fine. The ejection fraction could be totally normal, 60, 65%. The problem isn't the strength of the contraction. It's the stiffness of the wall.
A stiffness problem.
Right. Think of the heart like a water balloon. A normal heart is a nice, stretchy rubber balloon. It's easy to fill.
Okay.
A heart with diastolic dysfunction is like a balloon made of thick, stiff leather. You can try to fill it, but the walls just won't expand.
So less blood gets in to begin with. The chamber just can't hold as much.
Exactly. And if you can't fill the chamber, you can't pump much blood out no matter how strong your squeeze is. The cardiac output drops not because the pump is weak, but because the tank is too small.
And we see this a lot with, what, high blood pressure?
Long-standing hypertension is a classic cause.
Okay.
In a way, yeah, the heart's been working out too hard.
Right.
If you have high blood pressure, your heart has to push against that resistance every single second. So just like a bicep doing curls, the heart muscle gets bigger and thicker. We call it hypertrophy.
But a thick heart wall is bad.
It's very bad. It takes up space in the chamber, it gets stiff, it gets fibrotic, it can't relax.
Okay, so let's zoom out. Whether it's a weak, flabby squeeze, that's systolic, or a stiff, non-relaxing wall diastolic, the end result is the same. The body isn't getting the blood flow it needs. The organs are basically starving.
And that starvation triggers panic. This is the pathophysiology section of the source material, and this is where the story gets really interesting. The body realizes, hey, I'm not getting enough oxygen. It perceives a major threat.
But the body's kind of dumb here, right?
Yeah.
It doesn't know why the flow is low.
It has no idea. From the body's evolutionary point of view, if your blood pressure drops, if cardiac output drops, it means one of two things.
Okay.
Either you are bleeding out or you're being chased by a predator. It interprets heart failure as acute trauma.
So it hits the big red button, the compensatory mechanisms.
All the emergency protocols. And, in the short term, if you actually were bleeding out or running from a tiger, these systems would save your life. But in heart failure, they become the agents of destruction.
Okay, so let's walk through them. What's the first one?
First up is the sympathetic nervous system, the SNS.
The adrenaline rush.
The classic fight-or-flight response.
Yeah.
The body senses low blood flow, so the brain screams at the adrenal glands. Release norepinephrine.
And what does that do?
Two things immediately. First, tachycardia. It jacks up the heart rate. Second, it increases contractility. It screams at the heart muscle to just beat harder.
Which, on the surface, sounds helpful. If the pump is failing, tell it to pump harder and faster.
It sounds logical, yeah. But think about it. You have a failing, struggling, weak heart. And you are flooring the gas pedal. You're taking a horse that's collapsing from exhaustion, and you're whipping it to run faster.
A whipping the horse analogy.
It's the classic teaching tool. And yeah, you might get a little more speed for a mile or so, but you're going to destroy the animal. You're increasing the oxygen demand of a heart that is already starving for oxygen. It's toxic. It causes cell death.
Okay, so that's mechanism one, the adrenaline whip. Then the text talks about the Frank Starling mechanism. It got a little technical there, but the idea is basically about stretching. Right.
It is. The Frank-Starling law is a basic principle of physics. It just says that up to a point, the more you stretch a muscle fiber, the harder it snaps back.
Like a rubber band?
Exactly like a rubber band. You pull it back 2 inches, it snaps a little. You pull it back 6 inches, it snaps hard.
So the body tries to stretch the heart out.
It does. It tells the kidneys, stop making urine, hold on to all the fluid, wean this volume. It increases the blood volume to fill the ventricle more, stretching those walls, hoping for a stronger pump. It's trying to maximize what we call preload.
But again, there's a limit. If I stretch a rubber band too far,
it snaps, or it just gets loose and flabby and loses its elasticity. And that is exactly what happens in heart failure. The heart dilates, it gets too big, the fibers get overstretched, and they actually lose their mechanical advantage. So now you've just got this huge waterlogged heart that can't squeeze at all.
Okay, mechanism 3, vasoconstriction. The body narrows the blood vessels.
Again, just think about the bleeding scenario. If you've got a hole in a pipe, you clamp down on the pipe to keep the pressure up, right? You want to shunt blood to the brain and the heart.
Makes sense.
So the body releases hormones, like angiotensin II, to tighten all the arteries.
But the heart has to pump into those tight arteries.
Exactly. You're increasing the afterload. You're building a brick wall in front of the heart and asking it to push blood through it. It's like trying to drink a really thick milkshake through one of those tiny little cocktail straws.
Oh, yeah.
The heart has to generate massive pressure just to move a little bit of blood.
And finally, there's ventricular remodeling. The heart actually changes shape.
This is the long-term result of all that stress. The heart muscle cells, the myocytes, they start to change. Some get bigger to handle the load. Some just die off from all the toxic adrenaline. And in between them, you get fibroblasts coming in and laying down collagen, scar tissue.
So the heart becomes fibrous and stiff.
And it changes from a nice, efficient football shape into a big, inefficient sphere. A sphere is just the wrong shape for squeezing blood effectively.
So all of these things, the racing heart, the fluid retention, the tight arteries, the remodeling, they are the body's attempt to fix the problem.
But they are what drives the disease progression. And this is the neurohormonal model of heart failure. This is the most important concept for you to grasp. We aren't fighting the heart anymore. We're fighting the body's reaction to the failing heart.
And the text calls out the drivers here as the villains: angiotensin II, norepinephrine, aldosterone.
Angiotensin II is public enemy number one. It's an incredibly potent vasoconstrictor. It tightens those vessels. It causes fibrosis, and it stimulates the release of aldosterone.
And aldosterone's job is?
Aldosterone is the hormone that tells the kidneys to save the salt, and wherever salt goes, water follows. So you retain fluid.
Which increases blood volume.
Which stretches the heart more.
Which makes it fail more.
Which releases more hormones.
It's a vicious cycle, a downward spiral.
Exactly. And eventually, a patient just tips over the edge. The text talks about precipitating factors. Because it's rare for heart failure to be a smooth, linear decline. It's usually a series of crashes.
What causes a crash?
Oh, it can be anything that adds stress to this really fragile system. The text lists non-adherence as a huge one.
Meaning not following the rules.
Yeah. A patient feels okay, so they go to a party and eat a bag of salty chips. Or they think, I'll skip my meds for a couple of days. Suddenly the fluid builds up and boom, they're in the hospital.
Or a new medical event happens.
Right. A new heart attack, which is ischemia. Or an arrhythmia like atrial fibrillation. In AFib, the top chamber of the heart just quivers instead of beating. For a failing heart that needs every last drop of priming it can get, losing that atrial kick can be absolutely catastrophic.
Let's talk about what that catastrophe looks like, the clinical presentation.
Yeah.
How do we know someone is in heart failure? The text separates symptoms into primary and fluid overload.
The hallmark primary symptom is dyspnea, shortness of breath.
Okay.
Specifically, dyspnea on exertion. You used to be able to walk up 2 flights of stairs. Now you can only do 1. Next month, you're winded walking to the mailbox.
A lot of people get winded. I mean, I get winded if I run for the bus.
True. But this progresses to symptoms that happen when you're not moving at all, specifically when you're lying down. This is called orthopnea.
The number of kilos.
We literally ask patients, how many pillows do you sleep on? Because when you lie flat, gravity isn't pulling fluid down into your legs anymore. All that extra fluid just rushes back into your central circulation and floods the lungs. So patients have to prop themselves up just to be able to breathe.
And then there's the one that sounds absolutely terrifying, PND, paroxysmal nocturnal dyspnea.
This is the classic horror story of heart failure. The patient falls asleep just fine, but over a couple of hours, the fluid slowly redistributes. Then, 2 hours later, they wake up in a dead panic, gasping, coughing. They run to the window to get fresh air.
Why the window?
It's just instinct. They feel like they're suffocating because physiologically they are drowning. Their own lungs are wet. It takes a good 30 minutes of sitting upright for gravity to pull that fluid back down so they can breathe again.
And speaking of fluid being pulled down, that leads to the other major sign, edema, swelling.
Peripheral edema, yep. Gravity pulls the water to the lowest point. So if you're up and about, it's your ankles and your feet. If you're bedbound, it's your sacrum, your lower back.
And the text mentions a sneaky one, gut edema.
Yeah, the intestinal wall itself gets waterlogged. This causes nausea, bloating, what we call early satiety. Patients will say, Doc, I'm just not hungry. I take 2 bites and I feel full. It's actually a sign of worsening heart failure because their gut isn't working right.
So when you, as the expert, walk into the room, what are you looking for on the physical exam?
First thing I do is look at the neck. I'm looking for JVD, jugular venous distension. The jugular vein in your neck connects directly to the right atrium of the heart.
Okay.
So if the pressures inside the heart are high because it's failing, that pressure backs up, the vein in the neck just bulges out. It pulsates. It's like a little fuel gauge sticking out of their neck.
And when you listen with the stethoscope?
I'm listening for the S3 gallop. A normal heart sounds like lub-dub. Lub-dub.
Right.
And S3 is an extra sound right after the dub. It sounds like lub-dub-dub. Lub-dub-dub.
Yeah.
The way we teach it in med school is it sounds like the word Kentucky. Kentucky.
That's making that sound.
It's the sound of blood rushing rapidly into a dilated, non-compliant ventricle. It's basically the acoustic signature of volume overload.
And for the definitive diagnosis, we need technology. The echo.
The echocardiogram. It's just an ultrasound of the heart. It is the absolute gold standard. It lets us see inside the chest without cutting it open. We can see the wall motion. Is it moving vigorously or is it just barely twitching? We can look at the valves. And crucially, we measure that LVEF, the ejection fraction.
There's also a lab test mentioned BNP,
B-type natriuretic peptide. I call BNP the heart's distress flare.
The distress flare.
Yeah. When the ventricle gets stretched too much by all that volume, the muscle cells actually release BNP. It's a hormone the body makes to try to help. It tells the kidneys to pee out more salt.
So it's one of the good guys. It opposes the bad hormones.
It tries to, but it usually gets completely overwhelmed. For us doctors, though, it's a fantastic marker. If a patient comes into the ER short of breath and we don't know if it's their asthma or pneumonia or heart failure, we check the BNP.
And if it's high?
If it's normal, it's probably the lungs. If it's sky high, over 100, 500, 1,000, that's the heart screaming for help.
So before we get to the toolkit, the drugs, we have to talk about how doctors classify all this, because there are two different languages being spoken here, and they mean different things. The NYHA versus the ACAHA.
This is a really crucial distinction. The NYHA, that's the New York Heart Association classification, is subjective. It's based entirely on how the patient feels and functions.
So like Class 1 is?
Class 1, you've got heart disease but no symptoms. You can run a marathon, feel fine. Class 2, slight limitations. You get winded chasing the bus. Class 3, marked limitation. You get winded as just walking to the bathroom. And Class 4 is symptoms at rest. You're just miserable sitting there.
And you can move back and forth between those.
Exactly. I can treat you, dry you out with diuretics, and move you from a Class 4 back to a Class 2. You feel a lot better. But the ACA staging system is different. It's objective, it's structural, and it is a one-way street. You can never go backwards.
Once you hit a stage, you're there for life.
You're there. Stage A is high risk. You have diabetes or hypertension, but your heart is structurally normal. You don't have the disease yet. You're just standing on the edge of the cliff.
Yeah.
Stage B is structural disease. You've had a heart attack. You have a scar in your heart. Your ejection fraction is 35%. But, and this is the key, you have no symptoms. You feel totally fine. Stage C is structural disease plus symptoms. This is the vast majority of patients we treat clinically. And stage D is refractory. You have symptoms at rest despite being on every possible medication.
So most of the treatment section in our source material is really focused on stage C. The people who have damage are sick, and they feel it.
Correct. That is the battleground.
And the goals of treatment are pretty clear. Improve quality of life, keep people out of the hospital, and prolong survival.
And we have to be honest with patients. Those goals don't always overlap. Some drugs make you feel better right away but don't help you live longer. Other drugs help you live longer but might actually make you feel worse for a little while.
Let's start with the stuff patients probably hate the most. The lifestyle changes.
The diet. It is by far the hardest part. The text is very strict. Fluid restriction and sodium restriction.
How strict are we talking?
Max of 2 liters of fluid a day. And that's everything. Water, coffee, soup, the ice in your drink, everything. And less than 2 to 3 grams of sodium. Do you have any idea how little sodium that is?
Not much.
A single fast food burger can completely blow your entire daily allowance.
Wow. Why is this so critical?
Because of the pathophysiology we just talked about, the body is desperate to hold on to salt and water. If you give it salt, it will grab it and hold on for dear life, and the fluid follows. One salty pretzel can be enough to tip a stable patient into pulmonary edema.
And to monitor this, the text really emphasizes daily weights.
It's the single most important tool the patient has, I tell them. Weigh yourself every single morning, after you pee, before you eat. If you gain 3 pounds in one day or 5 pounds in a week, that is not fat. You can't eat enough cheeseburgers to gain 3 pounds of fat in 24 hours. That is water.
And that's the early warning system.
That's the signal. If we catch it there, we can just adjust their meds over the phone. If we ignore it, 3 days later, they're in the ER drowning.
Let's get into the drugs, the toolkit. We'll start with the symptom relievers, the diuretics.
The water pills. Furosemide, bumetanide, torsemide. These are what we call loop diuretics. They work in a specific part of the kidney called the loop of Henle to block sodium reabsorption.
So they basically force the kidney to dump salt and water.
And they are miraculous for symptoms. A patient comes in, gasping for air, drowning in fluid. You give them a shot of IV furosemide, and it works within minutes. They just start peeing out all that extra fluid. The lungs clear up. They can breathe again.
There's a catch, right?
The catch is that while they make you feel better, the text is very clear. Diuretics do not prolong survival. They manage the volume, but they don't stop the underlying disease process. They don't stop the remodeling.
And there's this concept of a ceiling dose.
Right. With loop diuretics, there's a threshold. Once you take enough of the drug to block all the available transporters in the kidney, taking more of the drug doesn't make you pee more. It just gives you more side effects, like hearing loss.
So if you hit the ceiling and the patient is still wet, what do?
You have to get creative. We add a second type of diuretic, usually a thiazide like metolazone. It blocks sodium in a different part of the kidney. It's like hitting the kidney with a 1-2 punch. It boosts the effect of the loop diuretic.
Okay, so diuretics keep us dry. Now let's talk about the drugs that keep us alive. The ones that actually interfere with that toxic neurohormonal model. The lifesavers. First up, ACE inhibitors.
Angiotensin-converting enzyme inhibitors, lisinopril, enalapril, captopril, these are the absolute foundation. Remember our villain angiotensin II, the one that clamps arteries and scars the heart?
Right. These drugs stop the body from making it.
Exactly. By blocking angiotensin II, you relax the blood vessels. That's vasodilation, which lowers the afterload. You stop the signal to retain salt. And most importantly, you block the signals that cause all that bad cardiac remodeling and fibrosis.
So these actually change the course of the disease.
They absolutely reduce mortality. They keep people out of the hospital. The text says they are recommended for all stage C patients unless there's a very specific contraindication.
But there is that one common side effect that drives people crazy.
The cough. A dry, hacking, ticklish cough. It happens because ACE inhibitors also block the breakdown of a substance in the lungs called bradykinin. About 20% of patients get it.
And if they get the cough, do they just have to live with it?
No, thankfully, we switched them to the cousins, the ARBs, angiotensin receptor blockers, so valsartan, candesartan.
How are they different?
So instead of stopping the production of the villain, they just block the door so the villain can't get into the house. They block the angiotensin receptor itself. Same benefits as ACEs, but no cough.
Okay, now for the drug class, that really seems like a paradox. Beta blockers.
Ah, yes. This is the one that requires the most explanation to patients. So beta blockers, drugs like carvedilol and metoprolol, they slow the heart rate and they reduce contractility.
Which sounds completely insane. We have a weak heart. Why would we give a drug that makes it weaker and slower?
Because we have to stop whipping the horse. Remember, the sympathetic nervous system is toxic. It's just bombarding the heart with norepinephrine, causing arrhythmias and cell death. The beta blocker puts a governor on the engine. It blocks that adrenaline toxicity.
So it forces the heart to rest and recover.
It allows the heart to fill better because it's beating slower, and by protecting it from all that adrenaline, it actually allows the muscle to heal. Over 3 to 6 months, the ejection fraction actually improves. The heart gets stronger because we let it rest.
But getting started is tricky. The text says, start low, go slow.
You have to be incredibly careful. If you take away that sympathetic drive too quickly, the patient will crash. We start with these tiny, tiny baby doses.
Yeah.
We double it every 2 weeks. And we have to warn the patient. You are probably going to feel more tired for the first few weeks. You might feel worse before you feel better.
That requires a lot of trust.
It does. But the long-term payoff is huge. It's one of the most powerful tools we have to extend life. But, and the text is very specific here, not all beta blockers work.
There are only 3 chosen ones.
That's right. Carvedilol, bisoprolol, and metoprolol succinate.
Succinate, not tartrate.
This is a classic board exam question and a very real-world error. Metoprolol tartrate is a short-acting version. It has no proven mortality benefit in heart failure. It has to be metoprolol succinate, the long-acting one.
Okay, so we have the big 3, diuretics for symptoms, ACEs, and beta blockers for survival. But the toolkit has gotten bigger. Let's talk about the add-ons for select patients. First, the aldosterone antagonists.
Spironolactone and aplerenone. So we mentioned that angiotensin II stimulates aldosterone. Well, even if you use an ACE inhibitor, this thing called aldosterone escape can happen. The body finds other ways to make it. So we just block the aldosterone receptor directly.
And what's the benefit of that?
Aldosterone is a major driver of fibrosis. It literally turns heart muscle into scar tissue. So blocking it keeps the heart more compliant. It reduces mortality significantly in patients with moderate to severe heart failure.
But there are risks.
Potassium. Aldosterone tells the kidneys to dump potassium. If you block it, you hold on to potassium. And hyperkalemia high potassium can actually stop the heart. So if a patient has bad kidneys, we have to be very, very careful.
And spironolactone has a particular side effect in men.
Gynecomastia, breast tissue growth and pain. It's because spironolactone looks a lot like steroid hormones, and it can block testosterone receptors. If that happens, we can switch to eplerenone, which is a cleaner drug, but, more expensive.
Then there's digoxin, the old school drug.
The oldest. It's extracted from the foxglove plant. It works by inhibiting this pump, the sodium-potassium ATPase pump, which increases calcium inside the cell.
In English?
It makes the heart squeeze a little bit harder. It's what we call a weak positive inotrope.
Does it save lives?
No. The DIG trial proved this years ago. Digoxin does not reduce mortality. However, it does reduce hospitalizations. It helps with symptoms. We mostly use it for patients who also have atrial fibrillation or for those who are still really symptomatic despite being on everything else. But it's got a very narrow therapeutic window. It's easy to become toxic on digoxin.
And then there's a specific combination mentioned. Hydralazine plus nitrates.
D-dill. This is fascinating because it's one of the first drugs ever to carry a race-specific indication.
The text says it specifically benefits self-described African Americans.
Yes. The HFT trial was a landmark study. It showed that in African-American patients with stage C heart failure who are already on standard therapy, adding this combination reduced mortality by 43%.
That's massive. Wow.
Well, the theory is that this population may have, on average, lower levels of renin and respond differently to ACE inhibitors, or may have a sort of nitric oxide deficiency that this drug combination fixes. It acts as a vasodilator. We also use it for any patient who can't take ACE inhibitors, for example, because of kidney failure.
So that's the chronic maintenance, the day-to-day battle. But what happens when the battle is lost? When the patient comes into the ER gasping for air, acute decompensated heart failure, ADHF.
This is crisis mode. The equilibrium is completely broken, and the text outlines a really useful mental model for these patients, the 2x2 hemodynamic subsets.
Right, visualizing the patient based on two questions. Are they wet and are they cold?
Exactly. Wet refers to congestion. Is there fluid in their lungs or their legs? And cold refers to perfusion. Is the heart pumping enough warm blood out to the extremities? Are their hands and feet warm, or are they clamped down and cold?
Okay, let's run the grid. Subset I, warm and dry.
That's the goal. That's a stable patient. High five, refill your meds, go on home.
Subset 2, warm and wet.
This is the most common presentation in the ER. The patient is pumping okay, they're warm, but they are totally fluid overloaded, they're wet. Usually because they ate too much salt or missed a diuretic dose.
And the fix is?
Dry them out. Big doses of 5-E diuretics, maybe add a vasodilator like nitroglycerin to open up the veins and reduce the preload, just help the heart empty a bit.
Subset 3, cold and dry.
This is a tricky one. The patient has low output. They're cold, but they aren't congested. They're dry. They might actually be dehydrated, or their heart is just failing to pump even without the fluid overload.
So you might actually give them fluid.
Carefully.
Yeah.
Very, very carefully. Or you might need to stimulate the heart with drugs.
And finally, subset 4, cold and wet.
The nightmare scenario, cardiogenic shock. They are drowning in fluid. Wet, but their heart is so weak it can't move the blood forward. Cold. Their blood pressure is often low. They look gray. They're clammy. They're confused.
How do you even treat that? It sounds like a paradox. You need to get fluid off, but their blood pressure is too low for diuretics or vasodilators.
It is a terrifying tightrope walk. You need to offload the fluid, but you have to support the pump first. This is where we bring out the big guns. The positive inotropes.
Dobutamine and milrinone.
These are the chemical whips. Dobutamine stimulates the beta receptors. It just slams the gas pedal down. Milrinone works inside the cell to keep calcium levels high. They force the heart to contract with more force.
But wait, we just spent 20 minutes saying that whipping the horse is bad, that it kills heart cells.
And that is still absolutely true. The text is brutally honest about this. These drugs increase cardiac output and make the patient feel better in the short term, but they may actually increase mortality in the long run.
So you're buying quality of life now at the expense of length of life later.
We're buying survival of the night. If we don't give the drug, the patient dies of shock today. If we give the drug, we might burn out the heart faster over time. We use these drugs as a bridge.
A bridge to what?
A bridge to transplant, keeping them alive until a heart becomes available. Or a bridge to a VAD, a mechanical pump. Or sometimes, unfortunately, as palliation, just to allow a dying patient to breathe comfortably in their final days.
The text also mentions a couple of other acute drugs. Nasiritide.
Synthetic BNP. It was really hyped as a blockbuster a while ago. It causes vasodilation and helps you pee out salt. But then a big trial showed it wasn't really better than standard care and was incredibly expensive. It's very rarely used now.
And tolvaptan.
That's a vasopressin antagonist. It blocks the hormone that makes you hold on to water, but not salt. We use it specifically for hypernatremia when the sodium levels in the blood get critically low because the blood is so diluted. It fixes the sodium number, but again, hasn't been shown to make people live longer.
So if the drugs fail, If you're in stage D, refractory heart failure.
Then we stop relying on biology and we start relying on engineering. We look at a mechanical circulatory support.
Like the intra-aortic balloon pump, the IABP.
That's a temporary device. It's a catheter we place in the aorta. A balloon on it inflates when the heart relaxes and deflates when the heart pumps. It sucks blood out of the heart and pushes it into the coronary arteries. It buys us a few days.
But the more permanent solution is the VAD, the ventricular assist device.
The LVAD. It's a titanium pump that's surgically implanted at the bottom of the heart. It literally takes blood from the left ventricle and shoots it directly into the aorta, completely bypassing the weak muscle.
And there's this crazy thing I've heard about LVAD patients. Is it true? They don't have a pulse.
It is absolutely true. It's one of the weirdest things you'll ever experience as a clinician.
Oh, wow.
The modern pumps are continuous flow. They just spin like a turbine at thousands of RPMs. They don't beat like a heart. So you feel the wrist of a patient with an LVAD and you feel nothing. But they're alive. They're walking and talking and living their lives.
And the ultimate solution?
Transplantation. Swapping the engine out entirely. But hearts are incredibly scarce. The waiting lists are very long. So for many, the LVAD becomes destination therapy. They live with that machine for the rest of their lives.
We have covered a massive amount of ground, from the cellular level of angiotensin II all the way to the titanium turbine of a VAD.
It really is a journey from the molecular to the mechanical.
So if we summarize, what's the big picture takeaway here?
I think the takeaway is that heart failure is this incredibly complex interplay. It starts with an injury to the heart, but it becomes a systemic disease that's driven by the body's own overreaction.
The helpful sabotage.
Exactly. The body tries to use these tools that evolved for acute trauma adrenaline, vasoconstriction, fluid retention to fix a chronic organ failure. And those tools just fail. They make everything worse.
So modern medicine is essentially the science of telling the body to calm down.
We are chemically turning off our own survival instincts. We block the adrenaline with beta blockers. We block the fluid retention with ACE inhibitors and diuretics. We're forcing the body to relax when every fiber of its being wants to panic.
And it's a balance between feeling better today with diuretics and living longer with that neurohormonal blockade.
And that requires a real partnership. It requires the patient to monitor their weight, watch their salt, and take the meds even when they're feeling okay. It is a very high-maintenance disease.
I want to leave the listeners with a final thought. We touched on the irony of evolution here.
It's just fascinating to think about the very systems, the RAAS system, the sympathetic drive, that evolved over millions of years to save our ancestors from a tiger attack or from bleeding out from a wound. Those are the exact mechanisms that end up killing us when the heart fails slowly over decades. Evolution prepared us for acute trauma, not for chronic organ failure.
So in a way, cardiology is the science of outsmarting our own evolutionary programming.
We are surviving by hacking our own biology. That's a powerful way to end.
It is. Thank you for walking us through the mechanics of the failing heart. This has been incredible.
My pleasure.
And thank you to our listeners for diving deep with us. Hopefully the next time you hear heart failure, you won't just see a stopping heart, but a complex, manageable, and honestly a fascinating clinical syndrome. Stay curious.